It's a real honor and personal joy in welcoming our next speaker, my dear friend and batchmate during our DM nephrology days in MMC, Dr. Vinoj, consultant nephrologist, Senthil Multi-Speciality Hospital. We both were fortunate to be trained under the legendary nephrologist Professor N. Gopalakrishnan sir. And today Dr. Vinoj will be discussing about the renovascular hypertension, an important and practically important topic. Over to you, Vinoj.
Thank you, sir. As sir told, we were fortunate to be trained under Dr. Gopalakrishnan sir, and it's a proud moment to have him here amongst us with the happenings of hypertension that is being discussed over the day. And this session being a tough one, that the first session following lunch, already people have gone for like 6 hours of constant hypertension related stuff. We have heard of endocrine perspective, a rheumatologic perspective, and the cardiologist perspective of hypertension. We heard the tidbits of hypertension from legendary Dr. Chenniyappan sir, and the nephrologist perspective too. So here I'll be confined, I'll take just 15 minutes of your time to bridging the gap between hypertension and ischemic nephropathy. A short brief review on what is going on. So for this we'll take two clinical case scenarios. One is a 23-year-old female. She had episodes of giddiness, headache and elevated blood pressure and no history of prior hypertension, cardiovascular disease. Examination reveals a renal bruit in the back and fundoscopy shows hypertensive retinopathy. So these are the clinical clues that we might have heard in the prior sessions. The initial blood investigations revealed that renal function normal and the plasma renin activity was elevated, and a Doppler ultrasound reveals an asymmetric flow velocities, and a CT angiography reveals a multifocal string of bead appearance. So this is classically a case of secondary hypertension secondary to renal artery stenosis, and this string of bead appearance, as you all know, is a classical marker of fibromuscular dysplasia involving the renal and the vertebral arteries. So this is a clinical case scenario 1, and this will be of relevance as we go through the literature in the forthcoming slides. The second case scenario is a 75-year-old gentleman who has a history of hypertension and has been on 2 drugs for the past 5 to 6 years. And he presented with an acute hypertensive emergency with an elevated blood pressure of 220/120 with bilateral basal crepitations, signs of acute pulmonary edema. He was stabilized with IV nitroglycerin and IV diuretics. The labs show an elevated creatinine, and like in our last case, the patient also shows a renal artery Doppler with evidence of high velocity flow. And this angiography reveals a critical proximal atherosclerotic stenosis of the right renal artery. He undergoes percutaneous transluminal angioplasty with stenting, and his blood pressure and renal function stabilize subsequently. So here, our second case scenario, this gentleman is a patient with atherosclerotic renovascular disease involving the ostium, the proximal lesion of the renal artery. So these two typical case scenarios, one, a 23-year-old female who presents in her early teens with hypertension and has a kind of renal artery stenosis that is multifocal, and here is a second case scenario who has a 75-year-old male with atherosclerotic renal artery stenosis. So these two are the broad ends of the spectrum of renal artery stenosis that we are dealing with. So the epidemiology and relevance, that is 1 to 5% of all hypertensives, there is an implicated renal artery stenosis. In resistant hypertension, there is 15 to 20%. In patients undergoing coronary angiography, there was a thing called drive-by angiography. When the patient's coronary arteries are being imaged, there is the dye is introduced down into the renal artery, and that has revealed that 30% of them have atherosclerosis overlap. And this study shows that there is about 29% of patients with hypertension have secondary hypertension, and among those 29%, the first common cause is primary hyperaldosteronism, as discussed by our Dr. Priyadarshini madam, endocrinologist, and the second common cause is renovascular hypertension. So the risk factors are a female gender, hypokalemia, either precipitated hypokalemia or unprecipitated hyperkalemia, no family history of hypertension, and a less body mass index. As Dr. Gopalakrishnan sir discussed, obesity and hypertension are intertwined. In the absence of obesity and a patient developing hypertension, you do suspect secondary causes. So routine screening is recommended for all hypertensive patients under 40 years, regardless of the BP level or medication count. is the AHA statement in their article. So the etiology, as we have seen, the two patient scenarios, clinical scenarios are very typical. So one is the atherosclerotic renal artery stenosis. This was the scenario 2, wherein a 74-year-old gentleman presented with accelerated hypertension. These are all imaginary clinical scenarios, just for a better understanding. This shows the presence of proximal ostial stenosis of the right renal artery. The atherosclerotic plaque gets occluded, and predominantly 90% of them are. The second one is fibromuscular dysplasia. These are classified based on the level of the artery involvement into intimal, medial, and perimedial. This is of prime significance for the postgraduates. And this is another pathological classification wherein we can see that this is the intima, media, and the adventitia. So this is an intravascular ultrasound that is an advance. We will be discussing about these in the forthcoming slides. An intravascular ultrasound showing, this is an OCT image that is showing that there is a dissection of the artery in this. And this shows there is hypertrophy of the intima and the media. These 6 lines are the media. And after dilatation, there is evidence of release. So angiographic classification of fibromuscular dysplasia. So previously was the histopathology classification, then comes the angiography. Based on the CT renal angiogram, we can see there is a single unifocal cutoff, there is a multifocal string of bead appearance that is seen in the pictures. So the other rare causes of renovascular hypertension are Takayasu arteritis, wherein we can see that the patient has a subclavian stenosis along with renovascular hypertension. There will be aneurysms and other syndromes, neurofibromatosis, etc. Acute arterial thrombosis can also cause renovascular hypertension in rare scenarios. So the pathophysiology of atherosclerotic renovascular disease. So this 74-year-old gentleman who has a renal failure, if at all he undergoes a stenting of the renal artery, are we expecting the patient's creatinine and the renal function to come back to normalcy? No. The main aim of renal artery stenting at that point of time will be to resolve him of his acute flash pulmonary edema, that is Pickering syndrome, and to reduce the total number of BP drugs. So the main pathophysiology behind this is the kidney adapts to hypoxic situations. So what happens is there is an ischemic nephropathy, there is microvascular rarefaction, and there is oxidative stress in the downstream of the kidney. So even if the kidneys are revascularized and the block has been relieved, the kidney function doesn't need to come back to normalcy. It is only the blood pressure and the Pickering syndrome onset that comes back to normalcy. There is already fibrosis, atubular glomeruli, and there is glomerulosclerosis. This has led to the advent of newer diagnostic modalities in the form of bold MRI, wherein the functioning part of the kidney can be assessed, and then revascularization can be decided based on the functioning capacity. This is also aided by captoperitoneal renal scintigraphy. So this, in our clinical presentation, usually RAS presents with resistant hypertension and explained kidneys with asymmetric renal sizes. So for postgraduates, any hypertensive patient, as previously been pointed out, head-to-foot examination is mandatory. Looking for all 4 limb pulses does not let you to miss any Takayasu arteritis. Looking for an abdominal bruit and looking for the presence of lower limb pulses is of utmost importance. And an ultrasound, as now the postgraduates are being currently trained in the curriculum with POCUS, ultrasound at the bedside. And that should reveal the presence of symmetric kidneys. If both kidneys are contracted symmetrically, we can brand them as a chronic kidney disease. If there is more than 1.5 centimeter difference in the 2 sides of the kidneys, then we call it an asymmetric kidney contraction. And then we should suspect presence of renal artery stenosis. Here comes the importance of having POCUS as a curriculum in our postgraduate period. And rapid decline after initiating a patient on ACE and ARB inhibitors and hypokalemia, flash pulmonary edema. So this is the Pickering syndrome is flash pulmonary edema. This is primarily due to the presence of increase of left ventricular end diastolic pressure and increase in the LA pressure. So these patients need not have a low ejection fraction. That is only diastolic dysfunction of the heart that causes rapid accumulation of fluid within the alveolar compartment. And this is usually corrected with correction of blood pressure. So these are the various diagnostic algorithms and values that we have. The basic investigation, the clinical examination, and the confirmatory imaging tests. So in imaging, we proceed from a simpler duplex ultrasonography. So in duplex ultrasonography, it is operator dependent. As our chair, Dr. Prabhakaran sir is here. predominant of the talk is going to be about radiological investigations. So duplex ultrasonography has an inter-observer variability. Obese individuals locating the renal artery and tracking them throughout the course from the ostium to the terminal branches is of great burden. And even after isolation, there is a very low sensitivity for the renal duplex ultrasonography. The parameters that are observed in renal artery stenosis is the main thing is the renal and aortic ratio, RAR. If the RAR is more than 3.5, there is evidence of renal artery stenosis. And the presence of a pulsus parvus retardus, that is a slow peak, is also evident of renal artery stenosis. So here we see this is the pulsus parvus retardus. There is a slow peak and there is no peak at all. So next comes the CT angiography. So as we saw, ultrasound is a good screening tool, but it has low sensitivity and but has a good specificity. If there is evidence of renal artery stenosis in Doppler, and there is a close evidence. Next we proceed with the CT angiography. This one is showing a proximal occlusion, proximal stenosis. So this has a higher sensitivity, but the only concern is our patients already have an elevated creatinine and renal failure. Hence, CT causes contrast-induced nephropathy, the major issue that we are concerned about. So contrast nephropathy predominantly is due to the high viscosity of the contrast medium that is being used. The only trials that have been proven to reduce contrast nephropathy are IV fluids with normal saline, and those is not tolerated by our patients with renal artery stenosis with pulmonary edema. Hence, CT angiography is still a difficult thing to make in patients with renal failure and renal artery stenosis. So the role of N-acetylcysteine and sodium bicarbonate supplementation to prevent contrast nephropathy is yet unproven. MR angiography. So this is a plain MR angiography that shows that there is evidence of stenosis here. So in the fear of contrast, we may think of MR angiography. Yes, MR angiography is a better diagnostic test when in the settings where a contrast needs to be avoided. But definition of the lesion and the structure of the stenotic point is not well defined in MR angiography. So for that, we need a contrast in MRI too. And there comes gadolinium. So gadolinium also has its renal adverse effects in the form of nephrogenic systemic fibrosis, that this gadolinium atoms get binded to the presence of copper, ferrous and zinc in the molecules, and that gets deposited in the interstitial tissue that activates fibroblasts and causes thin skin thickening. So in any patient with a GFR of less than 30, prior precaution has to be kept in mind before prescribing the patient with gadolinium contrast. And the next gold standard of diagnosis is the catheter-directed angiography. This shows a very well demarcated mid-segment stenosis of the kidney, and this shows terminal stenotic kidneys. So these are the various sensitivity and specificities of the various tests that are available. Here we can see that duplex ultrasound is less sensitive. And here we can see that the CT angiography is 100% sensitive and specific. So this is bold MRI. This is based on the presence of deoxyhemoglobin in the kidneys. Usually the medulla is a hypoxic area and cortex is normoxic area. So presence of tissue hypoxemia in the cortex in a bold MRI, this deoxyhemoglobin acts as a paramagnetic substance when it is exposed to this, and that reverts in shows in the MRI. So lighting up in an MRI shows that there is evidence of post-stenotic hypoxia. And captoperal renal scintigraphy in RAS. This also is utilized for the functional significance of renal artery stenosis. So in RAS, usually the perfusion is maintained by angiotensin II mediated efferent arteriolar constriction. And once the patient is given captopril, usually in the presence of this is the normal peak and trough fall of the DTPA or MAC3, whichever moiety that we are giving. So this is one kidney and this is the other kidney. So this is a grade 1, this is a grade 2A and 2B, and this is a grade 3 level of absence of uptake and peak in DTPA. So sometimes it can be masked. When patient is given captopril, this efferent arteriolar constriction that is being blocked causes the release of the primary lesion. So these are the two other advanced investigations that are available for evaluating the image of this is an optical coherence tomography, and this is an intravascular ultrasound of the renal arteries. So IVUS has deeper penetration but it is, shows an eccentric plaque. Whereas this OCT has a higher resolution and it is useful for a dissection diagnosis. And also this shows the thickening of the tunica intima and the media. So these are the treatment strategies that are available for renal artery stenosis. As we saw, stenting is not the treatment for renal artery stenosis. Before that, we have lifestyle modification, statins, antiplatelets, and control of risk factors like diabetes, smoking, RAS blockade, primarily in unilateral RAS, ACE and ARB, and percutaneous transluminal angioplasty is for select individuals. So these are the AHA 2022 guidelines for indications for revascularization. In class 1, recurrent flash pulmonary edema, progressive renal insufficiency, and resistant hypertension with hemodynamic RAS. So these are the several trials that have been done, and these trials were done in select individuals. So angioplasty versus stenting. So angioplasty shown to improve the lesion severity, and stenting is indicated only in select patients. So identification of whom will be benefiting from patients with stenting is that if the timing of the kidney function deterioration is less than 6 months and there is proteinuria is less, the cortical thickness distinct is more than 0.5 centimeter and the resistive index of less than 0.8 and a renal artery length of more than 8 centimeter. These are the indicators of there is a possibility of reversal. So these are the indications for revascularization in renal artery stenosis. So the clinical pearls: always suspect RAS in resistant hypertension with an unexplained renal failure with asymmetric kidneys. Imaging is the diagnostic test, which is primarily by an ultrasound followed by a CT angio or an MR angiography, keeping in mind the effects of contrast on the kidney and the system, and functional investigations in the form of bold MRI, scintigraphy to detect the feasibility and the utility of doing a stenting in these cases. Most patients usually benefit from optimum medical therapy and selective revascularization in bilateral RAS, flash pulmonary edema, and a progressive renal dysfunction. Thank you.
Hello. Wonderful presentation, Dr. Vinoj, as always. It reminds me of our golden days in Institute of Nephrology, MMC. You have covered all the salient points of renovascular hypertension. The take-home points will be when to suspect renovascular hypertension in a nutshell for the audience.
Yes. So, in patients with progressive renal dysfunction who have an unexplained renal failure, wherein the patient has an asymmetric kidneys while doing an ultrasound and a renal artery bruit in a clinical examination, that is very difficult to pick up unless dedicated examination is done, that too at the renal angle, or that is 2 centimeter lateral to the umbilicus. And these are the clues. And one is that secondary resistant hypertension with the presence of hypokalemia that is either provoked or unprovoked. And that too in patients with prior history of rheumatologic diseases like Takayasu's arthritis, we should suspect the presence of renal artery stenosis.
Any questions from the audience?
Yes, ma'am. Definitely, ma'am. Because the renal artery stenosis is shown to provoke hypoxia that triggers a series of cascade of events in the downstream ischemic kidney. So once the ischemic kidney starts adapting to itself, even after revascularization in the form of stenting or plasty, we don't reap the benefits of stenting in renal dysfunction point, ma'am. So prevention is definitely better than cure, ma'am. Yes, ma'am. Yes, ma'am. The ischemic changes that have been happening to the kidney responds in a way of self-destructive manner that causes interstitial fibrosis and tubular atrophy, ma'am. Sir. Yes, sir. Sir,
because to prevent it, we have to pick it up early.
definitely.
As you said, these are points you have said for what all you need, but picking it up early is a bit of a...
I think the radiologist, we have able hands like Prabhakaran sir, we can pick it up very easily. So because we send it for a scan and it gives us that there is an increase in resistive index. So it is it's a multi-modal approach, and we have if we have an able radiologist like us, we can easily pick up in with the ultrasound itself. As we said, it is an inter-observer variable parameter, sir. So the presence of high resistive index or a peak systolic velocity to the RAR, the renal aortic ratio, that can be easily picked up by the radiologist itself in a thin individual given.
To add in the, along with the Dr. Vinoj's statements, FMD usually responds very well to angioplasty. There is no need for stenting, but atherosclerotic lesions always need stenting. And while doing stenting, we have to protect the embolite to the distal also. So we can use balloons or filters. And usually femoral approach we can use it. Radial approach also can be. But doing stenting, we have to decide select the patients. All renal artery stenosis patient, no need for stenting. If mostly they will be controlled with the medications. Usually 3 medications or more than 3 medication requires to control this, or any adverse effect develops due to drugs, including using of diuretics, then patient may need for stenting. Otherwise, because of all RCTs, whichever Astral, Star, Coral, all RCTs what's telling is after stenting there will be no significant difference between the medical managed persons and these things. So selecting the patient for renal artery stenting is very important, not for all cases, and more than 70% is significant according to the AHA guidelines.
Ma'am? Bruvi? It's too difficult in obese individuals, ma'am. Yes. Very difficult in obese individuals. Only in lean individuals we can be able to.
Very nice presentation, Vinoj.
Thank you, sir. Thank you, sir.
Vinoj, you used to do regular seminars in our department so well. Yeah, Prem also. Actually, today I happen to be one of the moderators for the poster presentation by so many younger delegates. My deep appreciation to all of them. As I was said, the quality of presentation and the content wise, there can be some differences. It is bound to be. There are bound to be differences. But the very fact that they came forward to put across what impressed them in this academic meet itself deserves appreciation. And another coincidence is that out of 14, if I remember right, at least 5 papers were on renal artery stenosis. So it is not infrequent. Many a times it gets missed out. That's it. And particularly in children whom they present with, they have this renal artery stenosis due to FMD, because there is no practice of checking blood pressure in children. So many a times it gets missed. And detection of FMD, it can cure hypertension in that. That's it. And also I'm recapitulating one very interesting case anecdote when I was in KMC as HOD. Young boy, 12 years old, presents to pediatric department and then subsequently shifted to surgery because acute abdomen presentation. And they thought it is, I don't know on what basis they thought it was acute appendicitis. They opened up and they did surgery as well. But somebody, some good soul there, somehow they checked the pressure, it was 170 over 100. After appendicectomy also pain was persisting. And they detected high blood pressure, and then it occurred to them to refer to, and there was hypokalemia, so they referred to us. Actually, it was a classical presentation of a classical FMD. And then, those days there was no facility in KMC to go for plasty and all that. And we, with the philanthropist's help, we got it done outside, and plasty was done. The hypertension got cured on the table. The child was requiring 3 antihypertensives. Then the big question, why he developed acute abdominal pain? That's it. Actually, FMD is a disease of women. But out of the 5 variants, one variant, medial hyperplasia, is more common in young boys. And this particular variant of FMD has got a vulnerability to go for dissection. So the dissection, they presented as abdominal pain. So, and the dissection, and in that angiography, it was missed out because it's a 2-dimensional view. Unless you do IVUS, intravascular ultrasound, you will not be able to pick up dissection. So we think these diseases are very rare. Of course they are rare, but they are not infrequent. and we need to have an index of suspicion. Wonderful presentation.
Thank you, sir. Thank you, sir.
Thank you, sir, for that crisp and clear presentation on renovascular hypertension. Your concise approach truly helped simplify a complex topic for all the delegates here. May I now request our chairpersons to kindly hand over the memento to our speaker. And I request Dr. Anand Kumar sir, cardiologist, SMS Hospital, to hand over the mementos to our esteemed chairpersons. Thank you very much.